Good evening, participants and delegates. Thank you for joining Shield Connect. And today we are again coming back with the series Icon in conversation with Dr. Ritu. So today we have a special guest from Bangladesh with Dr. Ritu Santwani. And our speaker for the day icon is Dr. Professor Samina Chaudhary. So before I hand over the session to Dr. Ritu, let me give a quick introduction of our speaker. Dr. Ritu Santwani, ma'am, is an obstetrician and gynecologist and IVF specialist in infertility related to test tube baby. And ma'am is a co-founder of MAAM and board member of WSGC. And also let me introduce our icon for the day. So ma'am is
let's madam's bio will be visible.
Yes.
Yeah, change the slide.
Is it visible, ma'am?
No, it's on.
1 minute. Let me share once again.
Please share.
Is it visible?
Yes, yes, Nishan. Yeah.
So, Professor Samina Chaudhary, ma'am is chairman of OGSB Hospital and Institution of Reproductive and Child Health. Ma'am is president of Endometriosis Society of Bangladesh. Ma'am was past president of Obstetrical and Gynecological Society of Bangladesh. Ma'am is chairman of Endometriosis Committee of SAFOG. Ma'am is also member of FIGO Committee for Human Rights, Refugees and VAW. Ma'am is treasurer of Bangladesh Perinatal Society, BPS, from 2005 to 2019. Ma'am was also EC member of Bangladesh Menopause Society, Fertility and Sterility Society of Bangladesh, Gynecological Oncology Society of Bangladesh, University Grant Commission, ICDD, RB and CIPRB, Johns Hopkins Bloomberg School of Public Health from USA. Ma'am is also editor of Ben Jog, that is a journal, and since from 1989 to 1997. Ma'am is also editor-in-chief in OGSB for topic dengue in pregnancy management guidelines and advisor of OGSB guidelines, COVID-19 and women's health. Ma'am has presented paper in national and international conferences. Around 84 papers have been published by ma'am name, and 82 publications, 5 author of books. The field of interest of ma'am is safe motherhood, adolescent reproductive health, medicinal and midwifery education, IYCF, RTI, STI, and medical education. And ma'am also been awarded with Freedom Outstanding Women's Award. So I welcome you, ma'am, on our platform for today's session. And I will hand over the session to Dr. Ritu Santwani, ma'am.
So thank you, Nishan. Thank you so much for providing the platform too. And thank you, Chitra, Raj, and the Shield Pharma. A very, very warm welcome to our today's stalwart. Today's icon is the Professor Samina Chaudhary, madam. So as Nishant has already just briefed the CV of the madam, madam actually doesn't need any introduction. Once you go towards the Bangladesh side, only the one name comes in the priority, that is Professor Samina Chaudhary, ma'am. So we are very grateful to you, madam, that you have accepted our invitation. And friends, as all of you are aware, that March is celebrated as the endometriosis month. So today we are going to discuss a very, very important topic, the prevention of endometriosis. As we all know, though we all are practicing from 10 years, 20 years, still a lot of dilemma for the diagnosis of the endometriosis and the treatment of endometriosis. Lot of young doctors put me, when I posted this, lot of young doctors have posted me inbox, ma'am, whether we are going to discuss only about the laparoscopy, whether we are going to discuss about the Dynogest or the Leuprolide. So how can we prevent this endometriosis? So today, to enlighten us, the Professor Samina Chaudhary madam is here. Ma'am, a very, very warm welcome to you. Ma'am, this lovely flowers from our side, from the greetings of India to you.
So thank you very much. Thank you. Thank you very much.
And
And I feel,
yeah, ma'am. And welcome to all our dear delegates who have joined all across the geography. The program is going live on the YouTube also. Once the madam's lecture will be finished, me and Nishan jointly will take some questions. And I'm able to see some of my friends have joined from Egypt and some from the Lebanon. A very, very warm welcome to you all. So now over to you, ma'am.
okay, thank you very much for giving me so warm welcome. And this is the month of endometriosis, and that's why I have chosen the subject as prevention of endometriosis. Is it really preventable or not? We'll see. And now I want to share my screen. It takes time.
Okay, no problem, ma'am. No problem.
issue, ma'am.
It slows down. Sorry?
Yes, ma'am. It has been sharing.
Is it sharing?
Yes.
Yes.
Share. Now? Can you see anything?
Yes,
It-
ma'am.
Yes. Yes. Now we can see it properly.
So slow.
Sometimes it happens, ma'am.
Is it full screen?
Not yet.
It's very much slow.
But slides are visible.
Slides are visible. Yes, ma'am. Yes. Yes. Now it is.
Window. Full screen. Okay.
Yeah.
Yes.
Very
Yes,
good.
ma'am.
Yeah.
Okay, thank you very much. Endometriosis, is it a preventable disease? Let's see. And we know that this is the disease, it starts from womb to tomb. And everywhere it is there. And I saw a slogan that here, there, and everywhere is the theme of some of the country that they have shown that it is the month of endometriosis. They have given that slogan. And you know that largely it is invisible and voiceless. These are the girls and women, and they have limited or no access to information and little say in decisions affecting their lives. And if we see that what is the overall the magnitude of the problem, about 200 million of women and girls throughout the world is suffering from this. And there is a very delay in the diagnosis is the problem. It starts very young. And if we see that what is the impact on the individual, it says that start with early puberty, there is dysmenorrhea, and also chronic pelvic pain. And it also has a big societal impact, medical cost, surgical cost, caregiver cost, absenteeism, and reduced productivity at work. And it is a very big cost for the nation also. And it has been said that 1 in 10 women, but now the very recent statistics showed that it is increasing so much that it is about 1 in 5 women, 5 to 8 women. And you see that in Bangladesh, we have one statistics that 2 crore and 12 lakh women and girls are in the risk of developing endometriosis because we don't know who will develop it. And that's why we have given this month of endometriosis many programs, and this is one of the program in the webinar. And I want to say that Miss S, 14 years girl, she told that my first period started at 12 years for the last 9 months. I have severe abdominal and back pain during my period. It hampers my regular study. I have missed 3 class tests in the last week for this excruciating pain. Painkillers doesn't work. Frequently, I miss family programs and also festival reunions. Now I am getting frustrated day by day and I am becoming more introverted. I sometimes ask myself, when will this pain will be end? And they said to us that, can you give me a pain-free life? And this is another case highlights that this is Mrs. MK, 25 years, married for 2 years, and she has developed this pain, excruciating pain, since her menarche. And she told that, I am a school teacher and a married woman. At my workplace, I cannot concentrate on my work properly. Often I have to leave classes or staff meetings. On the other hand, I sometimes fail to contribute to household activities, difficult to maintain the proper relationship with my husband, thus causing marital disharmony. I don't know how long I have to go with it. Both of us are depressed. How I will be a mother? That is my question. I am worried about my students also. I try to communicate with my students who are facing similar problems because I know nobody listens to me and nobody understands my pain and sufferings. We have seen 2 cases, and these are the endometriosis impacts on quality of life. We have seen that in one study in 8 countries has shown that there is sexual life is hampered in 50% cases, relationship with family 36%, and performance at the work and school 35%, and so on. Thus, it is a chronic disease associated with severe life impacting pain during periods, sexual intercourse, bowel movement, and also urination, chronic pelvic pain, abdominal bloating, nausea, fatigue, sometimes depression, anxiety, and infertility. And it is said that it is an inflammatory and estrogen dependent disease. We know that golden word, prevention is better than cure. And in the dictionary of epidemiology, it is said that an action aimed to eradicating, eliminating, and minimizing the impact of disease and disability. The level of prevention. The primordial prevention reduces the emergence of risk factors, and primary prevention, it includes health promotion and specific protection. About the secondary prevention, early diagnosis and prompt treatment. Tertiary prevention, disability limitation and rehabilitation. Quaternary prevention is identifying patient at risk of over-treatment. And question is that prevention of endometriosis, why important? Reducing the healthcare burden, minimizing the protracted morbidity, avoiding poor quality of life. Is it at all preventable? And what, why, who, how will measure this preventive measure? What are we trying to prevent? Primary disease prevention, progression of the disease, and also the recurrence is a problem that should be prevented also. Why we are trying to prevent this? Because we know that it is a very painful life and quality of life is deteriorated. There is risk of infertility, risk of malignancy, and risk of other concomitant disease also. Who are we targeting for prevention? It is the teenagers, infertile women, and women with hereditary risk of endometriosis. Primordial prevention, restricting use of endocrine disrupting chemicals and avoiding EDC containing objects. Political social commitment should be there, health education must be there, and avoiding the stressful job and reducing the cesarean section. Research funding and also dialogue and awareness program is needed for primordial prevention. Primary prevention is aimed at protecting healthy asymptomatic women from developing endometriosis. Because of endometriosis, definitely it's unknown. The potential of primary prevention is very much limited. What the risk factor of endometriosis seems to be having a first degree family members with the disease, although the specific genetic origin of the association is still unknown. Is there a role of primary prevention of endometriosis? The epidemiological data suggests that risk group, the early menarche, short cycle length, long and heavy menstrual flow, and reducing gravidity and parity are associated with increased risk of developing endometriosis. And one important issue nowadays, it's very much coming nowadays about the neonatal uterine bleeding anyway. And it has been found that those who are suffering from neonatal uterine bleeding, they are at very great risk of developing this endometriosis. Developmental obstructive Mullerian abnormalities, especially their transverse vaginal septum, and there is a genetic correlation of the first degree and also with twins. And there is a school-based program for creating awareness on endometriosis and management program in Bangladesh. And before that, we have to sensitize the teachers and school of the school and also the authorities and also our guardians. And for that, we have developed a diagnostic algorithm to find out the high risk group of endometriosis in our survey. And there is a genetic predisposition meta-analysis of genome wide association studies identifies some single nucleotide polymorphism associated with endometriosis. Role of genital anomalies. Uterine cervical stenosis is a risk factor for endometriosis in menstruating women. When a surgical procedure needs to be performed on the uterine cervix, great caution should be taken to avoid the narrowing the cervical canal. And primary mobile retroverted uterus tends to be more frequent in patients with endometriosis, but data are very much limited. Imperforated hymen should be detected during neonatal period and treated surgically during infancy or before occurrence of menarche. Severe dysmenorrhea in adolescent girls fail to respond to medical treatment should be investigated by ultrasound examination in order to exclude congenital anomalies of the genital and urinary tracts. Mullerian obstructed anomalies are most likely to favor the development of endometriosis, and associated with genital anomalies usually regress spontaneously after proper surgical correction. The only potential sequelae being adhesions when formed. About it has been nowadays, it's a very hot topic that environmental pollution is it a risk? Yes, it has been found that many studies shown that available data regarding exposure to environmental pollution such as dioxin and polychlorinated biphenyls draw a firm conclusion about the risk of developing endometriosis in later life. And Cano Co. et al. In 2019, and nickel allergy seems to be a risk factor for endometriosis. There is significant association was found in diet and endometriosis, and it has been found that the girls and women who are taking fewer vegetables and fruits, particularly citrus fruit, lack of intake of the dairy products and more intake of red meat and coffee and trans fats. they are at risk. And about this primary prevention, we have to promote the health promotion is needed. And for that, we, in our diet, we have to take care of plenty of vegetables, fresh fruits, and vitamin D, and also polyunsaturated fatty acids containing diet should be taken. About the exercise, exercise increases the sex hormone binding globulin level and reduces the circulating estrogen. E2. Specific protection that the current use of oral contraceptives, but with caution and careful technique at the time of cesarean section, laparoscopy, laparotomy, and abdominal surgery. And about omega-3 and endometriosis, lack of omega-3 polyunsaturated fatty acid, and in the review of Hansel et al. On endometriosis, dysmenorrhea, and diet, one large included prospective cohort study reported that increase in intake of long-chain omega-3 fatty acids lowers the risk of endometriosis, while increasing unsaturated fatty acid intake increases. The risk of endometriosis indicating that there may be a modifiable risk factors also. This 2010. About the vitamin D and endometriosis, it has been found that reduced intake of food rich in vitamin D have relationship with endometriosis. Women with endometriosis were found to have lower vitamin D status when compared with women without endometriosis, and a negative relationship between vitamin D levels and severity of endometriosis was observed in study shown in 2020. And diet change, it needs already, I have mentioned that what should be the diet. And some studies nowadays say that gluten-free diet is about gluten-free diet become a common diet and lifestyle trends over the last several years. It remains unclear whether the diet is effective for this diet is effective for people without celiac disease, which makes a person insensitive to protein found in the wheat. However, a study in 2012, trusted source suggested that 75% of the 156 women who took part in the study reported a decrease in painful symptoms after following a gluten-free diet for 12 months. And this is one study, gluten-free diet, a new strategy for the management of painful endometriosis. And conclusion is that it painful symptoms will decreases after 12 months of gluten-free diet. Still, it is not, there is no randomized control trial, so we do not confirm about this. A link of physical activities with endometriosis, and it may play a positive role in reducing endometriosis associated with pain. There's Ritu et al. 2016. Fortunately, lifestyle change that lowers the endometriosis risk are also recommended for a variety of other symptoms and risk factors. Regular exercise is an important way to reduce the chance of developing endometriosis. Exercise 4 or more hours every week to reduce the body fat percentage, and which has a direct correlation with the estrogen level. Simple exercise to ease the endometriosis, different forms of exercise, and also yoga. Physical activity of endometriosis risk in women with infertility or pain in meta-analysis so that physical activity may reduce the risk of endometriosis. Impact of changing lifestyle on endometriosis-related pain. One study from Egypt has been shown that this study concluded that health education about changing the lifestyle, particularly dietary health education for women with endometriosis, have shown beneficial improvement. About alcohol, alcohol consumption definitely a risk factor of endometriosis. And about the OCP, oral contraceptive as a prevention, when comparing women with surgically diagnosed endometriosis to women Without a diagnosis of endometriosis, there is evidence that current use of oral contraceptives has a protective effect against development of endometriosis. But however, the protective effect observed in current user can be related to the postponement of surgical evaluation due to temporary suppression of pain. But the study shows that it relieves the pain, but not the disease. Can endometriosis be prevented? By OCP, among the different pathogenic factors involved in endometriosis, there is some that might regulate menstrual bleeding, estrogen stimulation, and also progestogenic prevention. Continuous gestation with OC or without estrogen may prevent the development of endometriosis by inhibiting ovulation, reduction of menstrual bleeding, anti-inflammatory effect of both, inhibiting ectopic endometrial cell, and inhibition of retrograde menstruation hormonally and mechanically prevent the pelvic cavity from the endometrial implants. About now, a very recent guideline 2022 that the recommendation from the primary prevention, I am going for it. Women can be advised of aiming for a healthy lifestyle and diet and reduced alcohol intake and a regular physical activity. The usefulness of hormonal contraceptive for primary prevention of endometriosis is uncertain. About the secondary prevention, early diagnosis is very important. Awareness among the clinician that is endo-mindedness is important. History, careful history, and clinical examination, and transabdominal ultrasound, TPS, and MRI and laparoscopy. Awareness among the women, it is said that catch them young. And so it is one of the strategy for secondary prevention. Prompt treatment to halt the disease progression and complication. That's why we have given the slogan of this year is halt endometriosis. Early correlation, early correction of obstructive pulmonary defects, upfront medical treatment, fertility is not of concern, and OMA less than, that is chocolate cyst of the ovary less than 4 centimeters, surgical conservation. Conservative surgery is better than radical one. The aim of early diagnosis and treatment for prevention and sequelae of this chronic endometriosis, thus adequate treatment for symptom control could be applied early enough, including strategies to enhance or maintain the patient fertility. Reliably early non-invasive tests are lacking, but such tests could facilitate management at all stages of the disease, since laparoscopy is invasive and not always appropriate. And the potential source of early and non-invasive testing are serum and cell study from blood, and endometrium from the menstrual flow, and also endometrial biopsies and imaging technologies, useful marker molecules for such tests may be discovered by molecular screening technologies, genomics, and proteomics. And molecular probes could also be applied in functional imaging technology, fluorescence mediated tomography. Nowadays, it has been found that it can be diagnosed by this way also. And tests reflecting functional aspect of endometriosis lesion are conceivable. Molecular marker may characterize biological features of lesion, invasiveness, inflammatory reaction, or alteration of the normal eutopic endometrium of patients. Functional characterization of the disease provides the basis of effective preventive and individualized therapeutic strategies. Inflammatory cytokines and chemokines, interleukin 6 and CCR1 have shown promising potential to diagnose minimal mild endometriosis, but their feasibility as early non-invasive test has to be confirmed prospectively in larger series of patients. About the reduction of retrograde menstruation. Retrograde menstruation is a physiologic phenomenon. Retrograde menstruation influences the risk of endometriosis by short cycle length and heavy menstrual flow. High risk due to Mullerian anomalies or stenosis of the external ostium, and retrograde uterine contraction could play a role. About the inflammatory reaction to discomated endometrial cell might withdraw the cell growth stimulation potential that some of these cytokines have. The inflammatory potential might be regulated by hormones and anti-inflammatory substrate. Continuous treatment with NSAID and specific COX-2 inhibitors might prevent the increase of prostaglandin derivative driven by the inflammatory cascade and estrogen. And vascular proliferation and support is a requirement of endometrial cell implantation, but the drugs available today are so far not suitable for preventive use. Specific inhibition of cytokines and important for the inflammatory reaction are available, but due to the general and several side effects, they are so far not suitable for preventive use. About the tertiary prevention, the disability limitation, that is relieving symptoms and fertility promotion plus minus, and upfront medical treatment, GnRH analog and GMPA, and Dynogest, and no contraceptive, oral contraceptives, because the estrogen component is making the growth proliferation of the endometrium. And conservativeness and also radical surgery. Conservative and radical surgery both are, but we have to think who is the right person. And prevention of recurrence is important. Optimal surgical clearance and post-operative medical treatment by a levonorgestrel intrauterine system. About some Chinese herbal medicine, it has been found that they are also working well. About rehabilitation, compensation of the loss in either may be needed HRT and ERT with maybe surrogacy or not. The quaternary prevention is number one, avoiding overdiagnosis and meticulous differential diagnosis, and reducing overzealous surgery, and reducing the ovarian loss and complication, because nowadays it has been found that many of the authors said that don't touch the ovary unless it is very much required. And before touching the ovary, you have to think not only 2 times, but maybe 10 times. And reducing the unnecessary artificial reproductive technology. The conclusion, creating awareness among schoolgirls, teachers, parents, healthcare providers, policymakers about the importance of menstrual hygiene and endometriosis. Social media should come forward to disseminate it. School curriculum should include about the menstrual hygiene and endometriosis to have a better womanhood. Now the slogan is be the voice of endometriosis warrior to combat endometriosis together. And you can see the logo of Endometriosis Adenomyosis Society of Bangladesh, and established in 2020 for better womanhood. And this year, you can see the poster of in our own language for common people. March is the month of endometriosis. So halt endometriosis, and there is a we said that if there is excruciating pain during menstruation, don't wait. Please come to a doctor, especially the specialist or OB/GYN doctor. So thank you very much for giving me the patient sharing. Thank you.
Thank you, madam. Thank you so much for such an excellent lecture. Dr. Nishant.
Thank you, ma'am. So,
Is it clearly audible?
yes, ma'am. Yes,
Ma'am,
yes.
clearly audible. Friends, if you are having any questions, please put. I am having a very bad cold, so today's the question will be taken from Dr. Nishant. Nishant, please take the questions.
Yes, yes, ma'am. So, when one question we received is how much risk is there of ectopic pregnancy due to endometriosis?
Actually, pregnancy is a problem. The tube is not the main factor, but the relationship is a factor. But it is also seen that ectopic pregnancy may be there because the tube sometimes it has been found that the tube is open, but functionally it's not that much working. So definitely there is a tubal problem, and sometimes it may happen that about ectopic pregnancy maybe.
And I got the second question. Does L-arginine helps in treatment of endometriosis?
L-arginine, I have got no idea about this L-arginine, whether it is helpful in the treatment of endometriosis.
Is there any studies, Dr. Nishant, regarding L-arginine? The doctor.
Ritu, can you respond?
No, ma'am. For L-arginine, for that, but I'm using some patients a curcumin extract. The curcumin extract, a lot of studies have come these days. So with the curcumin, the N-acetylcysteine combination, I'm using in some of my patients. 2 of my patients with the ovarian endometrioma. So I have used both the things, this Dynogest, cabergoline, and curcumin extract. So find the good results. A lot of studies are coming with this curcumin, but not for the L-arginine.
Even I read one study regarding green tea extract is also been helpful in getting a good thickness of endometrium.
And also the Chinese herbal medicine sometimes works.
Very true, very true.
Yes,
true. Some patients got a very, very dramatic results with this acupressure and all that.
Yes.
One of my patient, I operated her ovarian endometrioma in the December. And she earlier operated also 2 times. Every time the risk is there. So now till month of March, this March starting, she was pretty okay. Then yesterday only she called me, ma'am, I have heard somewhere for this acupressure. Can I start along with this curcumin? I told you can go ahead.
Yes.
Yeah.
Acupuncture is for pain relieving. Acupuncture works.
Yeah. Yes, ma'am.
And pressure also.
Yeah. Any more questions, Dr. Nisha?
Yes. How much vitamin D is to be prescribed to patient having endometriosis?
Actually, you have to give the vitamin D. It has got a range because it has got a toxicity if it goes over 100. So you have to between 30 above is that is the normal one is enough, and it depends on individual who needs how much. You have to see in the blood and you will test it, then you will determine that whether she has the normal vitamin D level. And one important issue, the exercise and also the sunlight is important. That's why it is also needed to have at least for 15 minutes to half an hour in sunlight. And whether it is covered or not, but still it works. If it is covered, still it works.
Thank you, ma'am. Thank you. Ma'am, your experience with Dynogest for the endometriosis treatment?
Very good.
Good.
But there is a problem of irregular bleeding, but with counseling, and sometimes we give progesterone single dose with this, and it covers. But I have found that when the patient gets it, and she is so happy that she don't want to, she wants to take it. She denies that I will not, I will continue this treatment.
Well,
she loves it.
Madam, usually here the different company persons are coming and meeting us for the 3 months therapy of Dynogest. But what
Yes.
my personal experience, I usually see the good results after 6 months only. What's your opinion, ma'am? Huh.
Actually, what we are doing, first of all, we have given for 3 months. Then, yes, I usually in my practice, I have given for 3 months first. Then I have to evaluate her again because we cannot say that you come after 1 year. That should not be. Because this is the patient, she will be with you and you will be with her. Because nobody will be separated from each other. Because this is a type of notorious disease. This is a very notorious disease.
Very true, very true.
And in one study I have found in this conference, World Conference on Endometriosis, one study from Japan, and they have shown that a randomized control trial about 1 milligram Dynogest and 2 milligram Dynogest in adolescent girls, because always we want that adolescent girls should have a very low dose that is preferable. And they have shown that 1 milligram dose and also 2 milligram dose, ultimately the effect is same. No one is superior. So because this is a drug is expensive. And in our country, we got this 2 milligram, but sometimes I'm thinking that in some people, I have to give this 1 milligram by making it half.
Okay. Thank you.
Because it will curtail half the price, because she has to take a long time.
True, ma'am. True. Yeah. So I think we have finished with the questions, Dr. Nishant.
Yes, ma'am.
So
thank you for the good questions. Thank you all.
Thank you, madam. Thank you once again for sharing your immense knowledge with us. And thank you, dear friends, who have joined all the way, all across the geography. Yeah, Dr. Nia Mohammed has joined all the way from the Saudi Arab, Dr. Francisco. So many friends I'm able to see. Hi, Dr. Milind, the king of Goa. Huh? Dr. Rekha from Kanpur. So many friends. Dr. Shabina from Mangalore. So many friends have joined. So I hope all of you have enjoyed the madam's lecture. Madam's lectures are always very, very nice, and lot of information we get from our lectures. So friends, those who have missed the lecture, the program has gone live on the YouTube. You can see on the live on the YouTube channel. Madam, with this, we will wind up for the today. Thank you so much, ma'am. Thank you so much once again for
thank you all the audience, and my salam to you. And thank you very much. And thank you for this.
Okay.
Thank you, ma'am. We got feedback. Thank you for this excellent webinar.
How much your audience?
Ma'am, program is going on the live tube that we can share you after some time, ma'am. After some time we can share you.
Yes.
Yeah.
Okay.
Thank
you.
Okay, ma'am.
Okay.
Bye, ma'am.
Bye.
Bye, ma'am. Thank you so much.
Halt endometriosis.
Yes.
Together.
Very true, ma'am. Very true. Thank you.
Should I leave?
Yes, ma'am.
Yes, ma'am.
Okay. Yeah. Okay.